Well, ready. So, alveolar bone. Some people call it the alveolar process. Is a part of the bone that hold the teeth. This part grow with teeth. So I had a patient. She's a very nice patient. She had a cleft lip and palate. She had an odontia. She doesn't have any teeth. So if you don't have any teeth, the teeth never grow. There's no alveolar bone, just basal bone. So she had a problem with denture, and already all these surgery and scars, she didn't have teeth, and also she didn't have alveolar bone. So alveolar bone will grow with teeth, and the problem is when you lose the teeth, it will shrink, it will be lost. Alveolar bone, we love it now because we love it before the implant. We love it because it holds the denture, and it holds the partial denture, the complete denture. Also, when now we have implant, it will support the implant. The implant would be engaged, and the alveolar bone would go called as integration. Other thing with the implant industry, it's billions of dollars industry. So sometimes I go on YouTube, or sometimes we watch lecture. There's a lot of misinformation because they try to sell you this. There was a lecture about mini implant, much better than regular implant. I almost believed that guy. He was like a big conference, and people watch him and very good. Mini implants is great, but physics and logic. Once I start working, it's a different. You need strong. Anyway, so every company try to sell you this thing, but sometimes there's a lot of misinformation, and they don't sell you the good information because of money. It's a billion-dollar industry. By Horizon, we have the greater thing. We use this thing and whatever. So sometimes the implant industry control the education, and we rarely see real lecture about implant or alveolar bone unless somebody sponsored that. So we don't have a sponsor. So tell you my experience. So alveolar bone is very important. We love it, and so it's fundamental of our work in restorative dentistry, implantology, prosthodontics. Once it's lost, it's very difficult, expensive to bring it back. Why the resorption almost on the buccal side, we lost more on the buccal side than palatal side. And the lower we have lose on the lingual side than the buccal side. Why? Blood supply. Palate is thick. Have good blood supply. Palate is very good blood supply. The buccal is very thin. And the problem with the anterior teeth, we have the anterior teeth. When you lose them, and you're going to do implant, you cannot use the same direction of the same tooth. You have to use so most of the implant will go this way. You go palatally to engage with the thick bone on the palatal side. So on this area. So the implant is going to be this way to engage this part, because we have less bone here. Another problem, if you lose the bone, the gum shrinks. Gum recession, one of the failure of the anterior implant is the gum recession, and pre-implantitis in general, inflammation of the tissue around the implants, because the tissue around the implants, they differ from the tissue around the tooth, because around the tooth we have dental ligament, we have cementum, we have Sharpie's fibers. These attach from the tooth to alveolar bone. The implant is re-contact, osseointegration. So different physiology, different pressure, even the bite, too much bite on the tooth can sustain some pressure because there is a ligament, has a flexibility. The bone, the implant does not. It will fracture. We have high fracture rate of implant more than teeth. So important to preserve the alveolar bone. So this part of the jaw bone support hold the teeth, composed of cortical bone, cancellous bone, trabeculate. It has holes in it. It's like alveoli in the lung. That's why I call it alveolar bone. Anchor teeth, periodontal ligament, maintain facial structure and especially in the anterior. When you lose it, the nasolabial angle should be 90. We saw the picture of Ari presentation. When the support for the lip will be gone, so it will look so ugly and look old. So this alveolar bone will maintain the facial structure, make your, remember, concave change to convex. So that's important. Another thing with the resorption of the maxilla, the maxilla when it shrinks, gets smaller, go backward, forward, upward, backward, upward. The mandible resorption will be downward, forward. So eventually, we have, the maxilla should cover the mandible. With resorption, the mandible go forward, so they have potentially class 3 jaw relation. And it will make more difficult for denture creation. We use flat teeth, most of the semi-anatomical, so we haven't do complete denture. Occlusion is stability more important, retention more important. Occlusion is going to be we have to do one of the third step after retention and stability. We have the occlusion, and we use almost flat teeth. And we prefer now the new books. We use 1 molar. Remember, complete denture we use 2 molars per second, especially in the lower, because the retromal pad go up like a curvature and reduce the stability. So we can use 1 molar, and most of the chewing in people with complete denture, they chew on the premolar area. For natural teeth, the chewing would be on the molars area. So that's important. Many causes of resorption. Tooth loss is the most important. Periodontal disease, infection, trauma, osteoporosis. This is systemic disease can cause that. Pre-prosthetic design and function. Sometimes ill-fitting denture can cause trauma to the alveolar bone or resorption and other things. Before the implant, I thought the alveolar bone is very tough. It's not. When you do the implant now, the temperature is 100 and 114. The bone if you drill, you have to have, when you drill to do implant, you have to have a good cooling system, and you have to go slowly, and you have to use sharp instrument, all to reduce the heat that will be generated when you're drilling the bone, because the bone is very precious, and if the heat's too much, lead to bone necrosis, and you don't see it immediately. The heat trauma, you see it later when the failure of the implant.
Is that because it's porous?
No, because it's very sensitive. It's very sensitive, it's very delicate. And I'm teaching people, especially when they do extraction, be gentle. And you know, that bone is very precious, and use less trauma. Make all the trauma, especially if you have upper molar, first molar, try sectioning the tooth. Upper molar has 3 roots, and almost always when they do without extraction, they fracture the buccal plate. And sometimes it goes with it. And sometimes when they do the wisdom tooth, they fracture the tuberosity. So if you can do sectioning the tooth and separate the roots, it will easily to be removed. And use gentle force, don't damage the alveolar bone. So alveolar bone would be very sensitive to that thing and get resorption. Why it's important to preserve the alveolar bone? Aesthetic, because without the alveolar bone, you lose the vertical dimension, you lose the support for lip, cheek, lips, both of them upper and lower. Sufficient bone required for osseointegration. Osseointegration when you put implant. The whole process of the bone holding the implant called osseointegration. We saw it with the last lecture when osteoblast will grow and goes on the fibers. Stability of the denture. If you have good denture, almost always you have good. If you have good alveolar bone, almost always you would have good retention, and good stability. If you have flat bone, that's the worst. That's very difficult. That's why you have to do different things. You have to do bone graft, or you do large, multiple implants to do overdenture. So once the alveolar bone lost, basilar bone may be affected. Even the basilar bone would be resolved too. The basilar bone, the mandible or the maxilla. Sometimes one of the cases, I'm showing the case of the genial tubercle. Genial tubercle is a process in the mandible on the lingual side is the attachment of muscle. Which muscle? Attachment. at the muscle of the tongue called genioglottal muscle. So this is like, it's a spine in the inner side of the mandible, and the bone shrinks all the way. There's a spine visible intraorally, because even the alveolar bone gone, the basal bone gone, and there's a spine in the middle, and it will affect our denture too. Also, it's very expensive. You have to do alveolar bone grafting. Another thing with bone graft, when you extract a tooth, there will be blood clot. There's tissue here. There's granulation tissue, fibroblast. Fibroblast is very fast. Osteoblast is very slow. So if you do extract the tooth and left the blood clot, there will be a fight between fibroblast and osteoblast. Guess who's gonna win? Fibroblasts. It's fast. It will generate so fast. You know, scar, when you have when you cut your hand, it will heal within a week. When you fracture your bone, need like a month or 2 months, because the growth and blood supply is different. That's why there's a fight between fibroblasts that make granulation tissue or the gum and osteoblast. So most people, what they do, when you extract the tooth, you fill it with bone graft and you put biological membrane. Biological membrane, what the biological membrane, it will guide the regeneration. Sometimes they call it guided tissue regeneration. Some book they say guided bone regeneration, GBR, GTR, depends on. So the whole thing to prevent the granulation tissue to grow faster than the bone or the osseo tissue. So if you extract the tooth, didn't do anything, the bone shrinks. If at least you fill it with bone graft and you put the biological membrane, there are many types of biological membrane. This is biological membrane. Some of them resorbable. The tissue or the body will digest them, but some of them non-resorbable.
Do they do that for all cases, or do they just do that?
This is expensive. You have to tell the patient, especially in cases if the patient wants implant.
Yeah, that's what I was going to ask.
Yeah, if the patient wants implant, he wants an alveolar bone. You have to need, especially anterior or posterior. Even the molar area, one of the problem with the bone graft in the lower molar area, which is the most common tooth to be extracted, is the lower first molar. Why? Because it's the first tooth to be permanent tooth erupted. Lower first molar. The first tooth to be erupted around 6 years old. Kids with 6 years old, they have baby teeth, and even the parents they think it's a baby tooth at 6 years old. So that molar it almost always has decay, unless you start doing sealant, gap sealant, to protect that first molar. The lower first molar is so one of the first teeth to be extracted. So this is a big deal about regeneration. How many show you? This is the case, Cody and a broken bone. We know the case. This patient has a root canal, number 9. So root canal, every tooth with the root canal has become brittle because there's no pulp tissue, there's no blood supply. The dentin would be brittle, and any trauma can be fractured. So he has the root still there, but he couldn't afford to do an implant. So what are you going to do? Keep the root. Keep the root because it has a root canal, and we make flexible partial denture until the patient, flexible partial denture, one option until the patient will have the financial and time to do implant. It makes a big difference. Smile. Yeah. So the root canal root can maintain alveolar bone, because whenever there's something, a natural alveolar bone attached to something through periodontal ligament, is still active, and still there's blood supply. One of the main blood supply comes to the alveolar bone, comes from periodontal ligament, and when you extract the tooth, the periodontal ligament is gone. So one of the blood supply to the bone is gone. That's why. And the other thing, we lose the physiological movement, the physiological pressure, and also sensation and the proprioceptive. We talk about
the awareness.
Yeah, that's the feel. So that's all these things important to alveolar bone. Conclusion: alveolar bone is very precious, and none really know. It cannot regenerate it. It's very difficult to regenerate it. Early intervention, modern technique can preserve bone. Anyway, and another thing with my experience, when I went to NYU, my teachers were periodontists. And there's always between oral surgeon and periodontists. But they worship the gum. They love the gingiva. So after experience with the work with the implant, I discovered attached gingiva is very important to the alveolar bone. If you have good attached gingiva, you will have a good alveolar bone. Even when you do implant and you put the implant and suture it and wait for it to heal. Some books they said do punch, remove like a circle to find to expose the implant. But when you do that, you remove part of the attached gingiva. So I stopped doing that. We just do incision and expose the implant, and you can suture it there because attached gingiva become precious. Because if you have a good attached gingiva, you have good alveolar bone, or good osseointegration and good healing implant. That's with experience. I didn't see it in the book, but maybe there's some articles. The other thing I told you about the implant, it's commercial. So sometimes you can read article, make everything rosy, and whatever, but then in the end they try to sell you something. So anyway, so alveolar bone is important, and we help us. Even we don't talk about implant. It's for if you have a partial denture, regular partial denture, or complete denture. If you have a good alveolar bone, you will have good retention, good stability.